So how do physical therapies fit into the broader US healthcare ecosystem?
Much more important to see a physical therapist first, get your body moving efficiently, and see what happens with that painful structure. Because if by getting your body moving efficiently, that painful structure calms down and you can do your function and you can get back to work, then you certainly don't want a hole in your knee if you don't need one.
Hello and welcome. You are listening to the podcast that asks the question too many people forget. What about rural health? I am your host, Chinasa Imo. Together, we are uncovering the stories, challenges, and innovations shaping healthcare in overlooked communities. Today, we will be discussing walking through pain, functional care financing in rural health. In rural communities, the body is not just a body. It is the means to their livelihood. Agriculture, construction, caregiving, transportation, and many other rural jobs depends on their physical strength, their mobility, and endurance. And yet, musculoskeletal pain is one of the leading causes of work-related disability globally, with rural community experiencing higher rates of chronic pains and injury, often with fewer options for early care. Rural communities and underserved settings, access to functional, preventative, and rehabilitative care like physical therapy can shape whether people remain mobile, independent, and able to work. Yet, those services are limited. What starts as pain in the knee, the back, or the shoulder can quickly become lost income, reduced mobility, or long-term disability. For many rural dwellers, taking time off to heal is not a choice, it is a risk. That is why today's conversation on rural health financing must include how we invest in functional care by looking at pain, movement, and access to care through a different lens. We go beyond asking what hurts to asking why does it hurt, and what can our health system possibly do to improve prevention and recovery. But before we dive in, let's take a quick break. If you are listening to this conversation, don't forget to subscribe to What About Rural Health on all podcast streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are also on YouTube. Your support means a lot to us, so please like, leave a comment, share, but most importantly, drop us a review. It helps others discover this important conversation. All right, welcome back to the episode. You are still listening to What About Rural Health with Chinasa Imo. Without much ado, let me introduce you to my guest. Joining me today is David Jetta. He's a physical therapist with a unique perspective on orthopedic pain and movement. Dave, as his friend calls him, approaches care by looking beyond the site of pain to understand the biomechanical dysfunctions that contribute to it, above and below the irritable tissues. He completed his physical therapy training at Eastern Washington University and earned his COMT certification from the North American Institute of Manual Therapy. His work sits at the intersection of skill manual therapy, functional movement, and long-term mobility. This is an important perspective for our rural aging population. So, David, I'm so happy to have you join us today. Welcome to What About Rural Health.
Thanks so much for having me.
So, how are you today? What have you been doing lately?
I am down visiting my best friend in Petaluma, California, and it's always a great time. I get to see him probably about once a year, and it's really nice to reconnect with the first person I ever met at college, and he's a really great guy. So it's been a lot of fun. But I'm also looking forward to getting back up to Spokane and diving into some of my list of things that I need to take care of.
That is wonderful. Thank you very much for joining us today. So to start us off, I would love to also bring our audience alongside. When people hear functional medicine and we ask, what does that mean? How do you often explain it?
I think I start to explain it by thinking about what is the job of a primary care physician. Okay, so when I think of a primary care physician, they are primarily looking at keeping the person out of disease for the organ systems and major health issues, things like cardiac care, in terms of high blood pressure, stroke and prevention, things like diabetes prevention, things like cancer screenings, things like looking at infection and all of the other body systems that can go on, making sure the person basically stays alive. And so when a person comes into a primary care physician and they have shoulder pain, for instance, the physician or the practitioner is going to look at that and determine that it is a musculoskeletal problem, and maybe it's a chronic problem. At that point, there's something that kind of clicks in their heads, and in my mind kind of says, well, no one's ever died from shoulder bursitis, and so this is not as important as all of the other things that I'm going to look at for this person. And kind of the medical community somewhat stops at the point where they say this is a musculoskeletal problem and it's not an emergency problem. And so hopefully they send that person to a physical therapist, and we start talking about why is that thing painful, and we start looking at the system, at the neighborhood in which that structure lives, and trying to decide why is there more pain, or why is there more stress on that painful structure. And then we need to figure out how we can improve the biomechanics of the situation of the whole neighborhood. Again, if we're talking about the shoulder, we're talking about the neck and the upper back and the shoulder blade and the collarbone, and making sure that whole region moves such that the rotator cuff, for instance, doesn't have as much stress on it.
Thank you so much for this explanation. Sincerely, the way you explain it now gives me, even like, I now have a good clarity of what it means when my doctor say go see a physical therapist, and I'm like, I don't know what a physical therapist would do for me that a massager would not do for me. So in looking at this layer understanding between massage and having a physical therapy, and I know that you've explained very well all of these mechanics of the human being and how you approach it, but like, what particular problems would you say you solve for everyday people through physical therapy that a massager would not do?
I'm doing a lot of joint mobilization. I'm doing some manipulation, some joint mobilization, some what's called muscle energy, and we can talk about some of what that means. But I'm also doing some myofascial work in terms of some massage and myofascial release. Sometimes we use there's a variety of techniques, and some of those techniques, I will say, people get very stuck on the technique. Are you working on the muscles? Are you working on the joints? Are you working on the nervous system? Are you working on neuromuscular control kind of things? And I think a lot of that sort of loses the forest for the trees, right? If you can get the person moving better and loading more efficiently, then the person's going to feel better. So there's a lot of myofascial techniques. Again, massage therapists can do a lot of great work with myofascial techniques to get a person moving and feeling better. And similarly, people always talk about like, oh, well, our chiropractor's better, our physical therapist better, and I think that that argument is sort of, again, missing the point. If we can get the person moving well, if we can get the person exercising, and then they're going to feel better. And I think there's goods and bads for all these different techniques. And if we work together as a community of practitioners, we can find what technique will work best for each individual patient. But starting at the premise of we need to get people moving efficiently first, then we can start talking about other more invasive things like injections and surgical intervention and whatnot.
Thank you so much for that explanation. And I want to bring you to your word, because I've seen a couple of places and times where you talk and you quote that practitioners often focus on painful, or rather, the system often focus on what is painful, while physical therapists will focus on trying to understand why it is painful. Can you explain what that different what did what that means in practice?
Yeah, I'll give you I think the really easy, simple example is patellofemoral pain or patellar tendonitis. You have a lot of people like runners or frankly everyday folks. If you're having pain going up and down stairs in the front of your knee, that is likely patellofemoral pain or patellar tendonitis. Now that knee is painful, and that is where the painful structure is. But when you think about what the knee only does one thing. It bends and it straightens. That's all it does. If you're standing with your legs relatively straight, your knee doesn't go side to side, and it doesn't do rotation. Now, if you are standing and then you turn your whole body 90 degrees to the right to go lift something up, you have to do a rotational move if your feet don't move, right? And that movement has to come from somewhere, and that movement should come from the ankle region. There's a bunch of different joints in your ankle that do rotation movements, and your hips and pelvis are supposed to, again, do that rotational movement. If you're not getting the proper amount of rotation through your ankles and your hips, then all of a sudden you put this extra stress of rotation on your knee. And if you do that extra stress of rotation on your knee, and then you go lift something up that's a little bit heavy, and add a load to that, then you've done something that the knee doesn't like to do, and then you've loaded it, and that is the kind of thing that irritates the knee. Again, similarly for runners, if your hip doesn't move the way it's supposed to, then you have to compensate for the lack of that hip movement in a way where that is going to create an abnormal stress on that knee. And so the answer is not to go in and try to get the knee and just say, knee, I want you to do better and be better and be able to tolerate all this excessive stress. It is to look above and below and say, hey, hip, you're not doing what you need to be doing. We're going to get you moving better, and then we're going to really start getting some dynamic strengthening in those planes of motion, those movements in which the knee doesn't do and should not be asked to do. I like to think of it like, so my other metaphor is I don't do taxes, right? I don't know what I'm doing. If you made me fill out all the tax forms, I don't know what I'm doing. I could probably watch a bunch of YouTube videos. I could probably talk to some people, and I could learn how to do that, but that is not my job, right? I'm the person who tries to get hips moving. And so if you try to make me do taxes all day, I'm going to be very, very unhappy. And that's similar to what a knee is doing when you ask it to do rotation.
Thank you so much for that response. Now, I want to now bring all of this to back into the system. So how do physical therapists fit into the broader U.S. healthcare ecosystem? But especially when we think about access and care in rural and underserved communities.
Well, we have a clinic up in Deer Park, Washington, which is a smaller town that is about 20 miles north of Spokane. And we find that there is certainly a great need for physical therapy access and treatment. We actually have a pediatric program as well. And I like the fact that we have a good relationship with the primary care physicians up there, and they again funnel people into our office to make sure they're getting care in the right order. I find that people kind of want to, they think that they need surgical intervention for whatever reason, and so they want to see a surgeon first. And what I would say is it's much, much more important to see a physical therapist first, get your body moving efficiently, and see what happens with that painful structure. Because if by getting your body moving efficiently, that painful structure calms down and you can do your function and you can get back to work, then you certainly don't want a hole in your knee, if you don't need one. And again, that's not to say that surgery is never a valid and important thing. It is. It just means that you need to get your body moving better first. And so, in the rural community, like you said in your intro, there's a lot. There tends to be a lot more physical type jobs, and so if you're doing a job that is more physical, that means your biomechanics and your load tolerance have to be better. You have to be able to tolerate all these different things. And some of that comes with the territory, because if you're working hard every day, then you're probably stronger than the average person to begin with. But if it's kind of one of those things where sometimes we have these smaller injuries and we don't think about them. I think about one time I slipped on the ice and I just kind of fell onto my hip, and I just landed really, really hard. I didn't really think about it too much, but what ended up happening was my hip and my pelvis kind of got a little bit jammed up and a little bit stuck. And that didn't really bother me too much. But what happened was, a couple of months later, I was trying to do a lifting task. I was helping some people move some hay, and I was lifting that big, huge hay bale. And my back did not like that, because again, my hip and my pelvis were not performing the job they were supposed to do, and my lumbar spine was trying to do the work that my hip wasn't doing. And so I had to unwind the fact that my hip wasn't working well, so that I could get my back to calm down and to get the whole system to strengthen up. And that's the kind of thing, especially for rural, hardworking folks, you need to make sure that they are moving really, really well, so that we can make sure that they are getting the appropriate care.
Yeah, I absolutely agree with you. Like, I'm a rural girl. I always say that. And I come from a very agrarian environment where landmass is just all green all year, because we farm different things. And within that, when you hear able-bodied men, they are not the guys in the city. They will be the guys who live in rural area who do able job, for why they are called able. And I'm just imagining what you just said. Right now, in rural environment where lifting is often a regular job, and someone had this kind of minor accident, but recurrently, like all of the time, you try to lift and then something crack and you abandon it. You be like, oh, that's okay, my body can take it, and that continues. What that would mean for that person's mobility, probably because they don't know what physical therapy is. Because I always have this understanding that people can always dream or desire to acquire what they know is in existence. So how would you place this where you have such scenarios in different pockets of rural communities, but there are really not much physical therapists or a structured primary care system that helps funnel, like you said, that helps funnel people who the physician would have examined to know, oh, they need a physical therapist?
Well, I think there are some physical therapists, especially through COVID. We found that we do have some ability to do some telehealth, and I don't particularly like that. I really like to get my hands on people. I really want to move some arms and legs and backs around manually because I'm a manual therapist. But I can appreciate that there is some value in having if you don't have access to a physical therapist, being able to go and go online and talk to somebody about your specific problem. I do not advocate, for the most part, getting on YouTube and finding that one cool trick to fix your knee pain, kind of stuff, because there's just a lot of really conflicting information out there, and it's always best to try to find a professional who can work with you and your specific needs. But you're not wrong. There's a lot more remote places in my state, Washington State, where there is very limited access to physical therapy, and even in our clinic, especially for our pediatrics program, we probably have a 4-month wait to get into physical therapy. So we do need a lot more practitioners, and we do need a lot more skilled care, and it's frankly, it is becoming more and more of a challenge. And I know that you're going to get into the payment and insurance thing here in the future, but that's becoming very challenging, especially in the rural communities, especially with Medicare, and the lack of choice and the lack of ability to have different options.
Thank you so much for that response. In fact, I was just kind of like imagining what that biggest gap is between the spread of the number of physical therapists that we have versus what the system, and I know you got a little bit into the health system and how it's all run by what health insurance can allow you to, right? So, but my question before we dive deep into that is, how do you see this thing show up, like for different people? I mean, in terms of demography, old, young, middle-aged, etc., especially when these people may be experiencing delayed care, they are paying out of pocket because there's no insurance, or they are coming to seek care only when the pain has become severe. Like, how do you think these things show up for these different demographics?
Yeah, for sure. We certainly see. I see a lot of people. Again, they feel like their knee is a problem and they need surgery. That's their sort of their mindset. And so they think, okay, I'm not going to go to physical therapy because my knee is bad enough that I need surgery. And so they go and they have surgery first without having physical therapy prior to surgery. And that to me is a big mistake, because there's a lot of evidence to show that we can make people much, much better surgical candidates prior to having that surgery, so that when they have the surgery, they come out and they have a much easier post-operative care. And I think that people think, well, if I need to do some physical therapy after, that's fine, but I have to fix the problem before I go to physical therapy. It's like, no, you need to improve how your body is moving so that you're taking stress off the structure, so that that surgical intervention, once it is done, you have less stress on that structure and that joint to begin with. So that's one of the ways that it shows up. And again, just like you're saying, delayed care, where insurance companies are now really ramping up a lot of copays, where people are paying $45 a visit for copay. I've seen up to $70 for a visit. And what's really crazy about that is that means the insurance company is probably paying me $20. The patient's paying $70, but the insurance company is paying me $20, which is like, really? That means you're not really paying anything for this person's care. And another piece on that is, insurance companies know that every dollar that they spend on physical therapy comes back to them as $1.25 in savings elsewhere. Because, I mean, most other care is incredibly expensive, and physical therapy is incredibly inexpensive for what, especially for what you're getting. And if I can take an older person, say a person who's 70 or 80, and I can improve their mobility and their strength and their balance such that they don't fall within the next 5 years, right? If you don't fall and break a hip, I have saved the systems thousands, hundreds of thousands of dollars in care. If I have some come in and work with them in such a way that they decide that they no longer need that shoulder surgery, again, that is thousands of dollars of surgical intervention care and medications and imaging and injections that don't need to happen. So yeah, it's
I absolutely agree with you. And like, I know, just from hearing the word like physical therapist means, um, like we had said, prevention, from further kind of long-term care, but it's also keeping people functional, right? However, I know, like, I'm just thinking from the capitalist economic mindset of every businessman. If a physical therapist is keeping people away from, severe care that generates more money, right? That means they might most likely not have the incentive to fund preventive care, because curative care would mean that, I don't know, but I'm just trying to figure out how can we, putting myself in this physical therapy space, now work with the healthcare system to reframe the importance of physical therapy in ways that it showcases broadly the protection of the overall economy, because a working force is a thriving force. A thriving force is a thriving economy, right? So how might we have this conversation, or how might you as a physical therapy practitioner have this conversation in ways that the system begins to see how to prioritize financing preventive care?
Yeah, no, it's a big challenge because everyone has. I always like to say everyone has a hammer, and we're all looking for a nail. And the physicians who are doing injections are looking to do injections with people, and the physicians who are doing surgery are looking to do surgery on people, and they're not really thinking about how the whole system works, and we're very siloed in our little section of what we do. I would like to think that physical therapists are a little bit less siloed in that realm, because we're working with primary care physicians and injection folks and surgeons all together. And I don't know. I mean, that's one of the reasons why I'm trying to get out and talk about this stuff in platforms like yours, and just talk about what is physical therapy and why should you start with physical therapy if you have a musculoskeletal condition that is not emergent, right? If you don't have a fracture or a dislocation, or if you don't have, if this has been going on for quite some time and it's not, it's not a big infection, or we've ruled out major pathology, then that's, where you should start is physical therapy. And I try to talk to physicians about this, and I also try to talk to surgeons and say, that the research really does demonstrate that if we can do physical therapy before you cut on this person, you're going to look better. Your outcomes are going to be better, and the patients are going to be happier. And I think, I don't know, there's sort of a scarcity mindset, I think, in the surgical world, where they feel like, well, there aren't enough patients to go around, which, I don't know, it seems silly, because it seems like the surgeons are always backed up, months to get in there. So I can't really explain it. I can't really explain why the medical community doesn't really think about, um, and I won't say they don't at all, but a lot of the medical community doesn't think about doing physical therapy first. I'll give you an example of something that's really frustrating to me these days. Is there are several insurance company plans that require a person to go to physical therapy for at least 6 visits prior to getting authorization for an MRI. And physicians know this, right? They know that they're going to get denied for this MRI on the shoulder if the person hasn't gone to physical therapy. So the person comes in, they say, "Hey, my shoulder's really painful. I don't know what's going on." And the physician says, "Okay, well, let's look at it. Okay, we need to get an MRI to see what's going on, but the insurance company won't pay for anything until you do 6 visits of physical therapy. And so just go to physical therapy and do the 6 visits, and then come back after you've done your 6 visits, and we can see what's going on," quote unquote. And it's like, well, that's not right. That's not the right mindset. People come in, they say, "Well, I just need 6 visits, and then we'll go figure out what's going on." It's like, no, no, no. We're going to do this physical exam here. We are going to decide what is both the irritable tissue by looking at how the shoulder is moving and doing special tests and stressing it in different ways in your history, and actually talking to you and looking at you. And then we're going to see what the biomechanics of the situation are of driving why this tissue is painful, and we're going to hopefully resolve it without doing an MRI. I mean, the idea that you need this picture to tell you what's going on is just flat out wrong. And the idea that a physical exam is the best way to determine what the best course is for that person is 100% right. I'm not saying that imaging isn't necessary ever. And I'm not saying that when you see something that looks a little bit hinky, that you shouldn't get some imaging to rule out, again, things like infection, things like cancer, things like an occult fracture, a fracture that is very hard to see. I mean, there are reasons to get imaging, but that should probably not be the first step in the process, I guess.
I absolutely agree with you. Like so many imaging, and generally in medicine practice, so many tests and laboratory requirements that physicians send patients to do. Some of them are absolutely unnecessary if we start from the right footing, which is, I guess, to give it to the insurance process, that I think in some way they were thinking about it, like, do physical therapy. Let's see if that tissue problem you're having in your shoulder could get resolved by physical therapy. And if that is not the case, then an MRI can show us other things that could have been causing that, and not just, oh, go do physical therapy so you can check the list, right?
Yeah, and I think, and again, I want to point this out. The insurance companies are actually correct, right? Just exactly how you're saying, right? The insurance companies are correct in saying you should do physical therapy before we do this MRI. But the mindset of the primary care physician and the patient becomes totally flipped in such a way where physical therapy almost can't work, right? If your physician has said to you, "Well, we can't know what's going on until we get this MRI, but you can't do your MRI until you do physical therapy. Just jump through the hoop of physical therapy." You're already in this space where you think it's going to be worthless, and so for sure it's going to be worthless. And so that's a little bit of a frustrating thing. But you're right in the sense that the insurance company is correct. But to me, the reason why you get an image is because you have done a physical exam and a good history, and you see how this person looks in a variety of different ways medically, to say this person looks as if they need a higher level of care. They look like they could benefit from a surgical intervention because I'm seeing these signs and symptoms, and they're saying these things. This is the history of their mechanism of injury, and and what their symptoms are, and I can do these special tests. Okay, this feels this way, or it doesn't load this way. This person looks as if they could benefit from a surgical intervention. That's when you get an image. Like you appear to be not 20 years old. Am I true in that?
Yes, you are
So
correct.
so I can tell you, if you had an x-ray on your low back or your neck, you're going to have some degenerative changes in on that x-ray today, right? If we took an x-ray of you today, and again, assuming that you don't have significant neck and back pain today, you're going to have those degenerative changes show up. Now, if you go fall and injure yourself in some way, and a week later you hobble into the primary care physician's office and you say, man, my back is really killing me from this fall I did a week ago. And the primary care physician says, okay, well, let's take an x-ray of it. They take an x-ray and they say, you have all this degenerative disc disease on here. It's like, well, okay, but you had that 3 months ago, 5 years ago. Who knows? I mean, like how, depending on, those are somewhat normal changes. And then again, it doesn't mean that some of that stuff can't get aggravated, and some of that stuff isn't necessarily some of the source of the pain, but that image didn't really tell you any interesting information, right? Where there's no big red arrow that is pointing to this thing saying like, this is the problem, this is the new thing that happened. Again, unless it shows up with something like a fracture or something like a dislocation or something like an infection or cancer. I mean, like there are things that images can really show that are significant, but I would argue that the vast majority of what we're seeing on images is not really important information, and it just sounds really scary, like spondylosis, and you have stenosis, and impinging on the fecal sac, and I mean, it just, like, all these words sound very scary, and people click into my chart and they read what the radiologist wrote, and they get all freaked out about their mild disc degeneration. It's like, well, you're not 20 years old.
Thank you for that clarification. To our listeners, as you listen to this conversation, I want you to reflect. And please feel free to leave your comment or opinion in the comment section of this episode. What would you change in your community if functional care, like physical therapy, rehabilitation, and early pain management, were treated as essential and not optional part of healthcare delivery? So, Dave, I'm coming back to you. In rural communities, we've talked a whole lot about pain, and within that setting, pain cannot just be described as a discomfort of the body structure, because it's tied to, their economic abilities and how they provide for their families. What would access to physical therapy and functional care feels like if we bring this closer to places where is already, like, we're in places where it's not in existence? And I know you've talked about telehealth, and I'm just wondering to myself, telehealth, how can you tell me via phone or Zoom video how my back could work? You know what I mean? If I am not going there. So how do we make sure that these things come a little bit closer to these communities, knowing fully well that, in fact, as important as a primary care physician is to rural environment, right? That is as important as physical therapy is to them, because of what we already established. Their body is the main functional part of their economic mobility. So how can we bring this care closer to them?
I think there's a tremendous value in in thinking about some really basic ideas in exercise. So I'll give you an example of I get lots and lots and lots of patients who are in the realm of 65 years old with low back pain. Right, that is very, very common, and many of these folks have retired, and they're doing a lot of sitting, and they're not doing much. They're not doing much else. And I really talk to them about, obviously we get their back moving better and their hips moving better and some better strength and whatnot, and get them feeling better. But then I start having a conversation with them about what I think of as four pillars of exercise, and that is flexibility, strength, endurance, and balance. Right, and everyone, regardless of your age, should be thinking about those four things, and maybe some others if they want to do some other things. But if you have a program that has components of flexibility, strength, um, endurance, and balance, then you are kind of hitting on a lot of really good functional ideas, and that's the kind of thing that can keep you independent in your home for much longer. And I talk about my, again, my 65-year-old folks, and I say, if you really worked on these components, especially the balance component, you're the kind of person who is going to be safer in their home for longer. And you may not see these amazing gains in your abilities, but what you're going to see is that after that decade is over, your friends who aren't doing anything are going to kind of fall off a cliff in terms of their balance and their function and their endurance, and they're the people who are going to fall, and they're the people who are going to break a hip, and that becomes a sort of a catastrophic situation. So in the context of rural health, and in the context of having practitioners who are not necessarily available, then we start talking about what can we do with Tai Chi groups, what can we do with other yoga and flexibility exercises, what can we do with Zumba classes and other lifting things in terms of strength, Pilates, or whatever. I mean, the reality is it doesn't matter what you're doing in terms of exercise, as long as you are working on flexibility, strength, endurance, and balance as just some basic tenets. And I think, if I always kind of say, if everyone did yoga from the age of 5, then I wouldn't have a job. No one would need to see me if everyone kept their body moving efficiently and had the strength and balance that comes with a lot of these more ancient exercise routines. So again, as communities, they're finding some resources to get people moving, and especially in the balance realm, and especially with older folks, that can be tremendously important to both their well-being and their ability to stay independent.
Thank you so much. But you mentioning yoga, I think I should go and enroll in one. Not that I want to keep you out of your job, but
I would love it. If all of my patients, honestly, okay. So let me preface this a little bit. I also think that there are lots of people who are very much not moving well. They're stiff in a lot of different places. When they try to do yoga, it doesn't work out well for them, because when they try to do a lot of those moves, they end up the things that aren't moving still don't move, and some of the things that are irritated end up trying to compensate for that. So I think that people need to get moving better before they start doing things like yoga, which is why I say from the age of 5, right? If you start doing yoga when you are moving well and you maintain the ability to move throughout your life, fantastic. If you are 60 and you just try to do the heavy duty yoga class, that is probably not going to go well for you, and you certainly need to make sure that you're getting your body moving efficiently before you just dive into a big program.
Thank you very much. Let's go for a short break. When we return, we'll pivot to discussing financing the body. Do you have a rural health stories that need to be heard? Whether you are a health worker, patient, policymaker, or advocate, we want to hear from you. Share your story on our website at www.whataboutruralhealth.com/stories and help us amplify the realities behind the data. Someone from our team will contact you with detail on how to get your story published on our newsletters, websites, and other media platforms. All right, welcome back. So, Dave, let's talk financing. We have comfortably established the fact that physical therapy is often underutilized, right? And even though it can reduce surgeries, imaging, and long-term disabilities, and support people to stay at work, there are two-part problems that we have seen that is tied to the problem. One of them is limited access, and the other one is underfunding. So what do you think about these two things?
I think that physical therapy is very economical. And if a community was going to get the most bang for their buck, coming together and hiring a professional who can do that and bringing that person to your community on a once a month basis, and having that person come for a day, and having who wants to see that person and work on whatever they want to work on, and maybe do a group class and some other things, would be an incredibly valuable use of those funds. If you can get people to come together and decide that is the way to go. Now, they might find that other parts of the healthcare realm are more important. Again, I come back to the idea that no one ever died of shoulder bursitis, and lots of people die of lots of different diseases that can and should be looked at and addressed before we start messing around with shoulder pain. But from a physical therapy standpoint, group classes can be really valuable as well. When you have people who have, again, maybe some balance problems or some flexibility problems, you can get a professional in. You can do group classes where the person can adjust things either up or down based on individual needs, but everyone can do similar kinds of exercises, maybe with the help of a family member to make sure that they don't fall or whatever. But again, physical therapy, an average visit in my town, right, in my city, an average visit would be in the ballpark of a cash pay visit would probably be anywhere from $100 to $150. And that is not that, that's not inexpensive. But when you think about how much people would spend on other forms of care, and if you miss a full day of work, that's a pretty low price. If by going to 3 or 4 visits of physical therapy, you don't miss a week of work, you're definitely going to come out on the right end of that economics equation.
I like the perspective that you brought in terms of what communities can do, because parts of the reason why we started this series, reimagining health financing in rural communities, the opportunities and the challenges in there, is that, and part of my previous speakers have established this shrinking tests between government and even other investors in putting money where all of our mouths should be, right? And when we look at these, we now begin to imagine what can communities do within themselves to support their needs. And this is just one pure model that could potentially help solve rural communities' problem. We know that physical therapists are scarce. However, they are private practitioners, right? They are physical therapists who are in peri-urban and suburban environments that rural communities can access if they come together and figure out a funding mechanism that can allow this person come periodically. And then this is where I would tie in the telehealth system together. There's a physical therapist that comes maybe once or twice in a month, and then there's a follow-up with telehealth, right? This could potentially open a whole lot and solve a whole lot of issues with the access without necessarily overburdening the health system. So thank you very much for bringing that point out. But I want us to specifically name it as it is. And I know you raised this conversation a little bit earlier on when you talked about insurance and reimbursement and stuff. And how does that shape who gets physical therapy and when we talk about insurance and the reimbursement methods that, the health system operates in?
As far as I know, every healthcare plan that is sold in my state, in Washington State, has physical therapy as a requirement. It has to cover physical therapy to an extent. But some of those plans only cover 6 visits. And so that's in some ways that can be challenging. If you have normal average low back or shoulder pain and you come once a week for 6 weeks, that's going to be, for the most part, that's going to be fine, right? That is going to be adequate. If you end up having a stroke and you need a lot of outpatient rehab to try to learn to walk and move your arms and do all the different things that might be limited after a stroke, that is definitely not going to be enough physical therapy. So again, different healthcare plans offer a wide variety of physical therapy benefits. And I think the other piece is that the payment that physical therapists get from insurance companies is becoming more and more of a problem, because that number, the average reimbursement rate, has not changed since 1995. And that's really crazy. If you think about what you paid for a car or a house in 1995, or again, space in a commercial building to rent in 1995, and you think about how much you pay for those things now and how hard it is for a practitioner to even kind of break even. So I think there's a real problem with physical therapy in the economics of physical therapy. When I see students coming out of school and they have $150,000 worth of loans or more, that's $150,000. If you went to a state school, that's a relatively inexpensive version of physical therapy, and they need to make a lot of money to pay off of those loans, not to mention buy that house and maybe have a car, and maybe they want to go on vacation once a year. The economics become much more challenging. And I come back to the thing that's really frustrating for me is insurance companies know that when they provide good physical therapy, they pay less elsewhere. And I don't understand why we're still having this fight about getting people more visits and working with people in a way where they are avoiding more costly and invasive medicine. I can't tell you, it happens all the time where people will say to people, okay, well, we have to, if you'd like to continue, we have to go on a cash-based payment system, and typically people say, that's not going to work for me, and they stop going, and they go back to their primary care physician and says, well, my shoulder still hurts. I went to physical therapy, but my shoulder still hurts. And so the primary care physician says, okay, well, go see the surgeon, see what they have to say. And again, that's not to say that the primary care physician is doing anything wrong, and it's not even to say that the surgeon is doing anything wrong, because the surgeon's going to do an MRI. They're going to see something in that shoulder that could be done, a surgery that could be done. But because we shortchanged physical therapy on the front end, we now have tens of thousands of dollars of extra care on the back end that could have been prevented if the insurance company just said yes to 6 more visits of physical therapy or 12 more visits of physical therapy, which is incredibly inexpensive for them to pay for compared to all the other things.
I absolutely agree with you. And while you were talking, my mind keep going to the question that I had about, quality of care and patient's outcome because surgery leaves a scar, right? And for many people, that is long-term recovery, and some they never get to recover because I have not seen a prognosis for surgery that would give you guarantee that you get 95% full-term recovery, right? So what does that leave in terms of overall health outcome for the patients?
Yeah, again, I know that when I make it sound like surgery is a bad thing when I talk, and that is definitely not my attitude. Surgery is necessary in a whole host of cases, but the more we can weed out the people who don't need surgery. That's the thing. Like if you don't need surgery, you don't want to have surgery. Right. I know that sounds like a very simple thing, but if surgery is going to benefit you, then that's great. And you can absolutely have an excellent outcome from a surgical intervention if that is going to be the beneficial thing for you. I would argue there's almost no one out there who could benefit from surgery without doing physical therapy first, because again, so I am certainly not saying, I'm not putting surgery in a negative light. All I'm saying is that selection of patients who need surgery should be done a little bit more, as opposed to what I see now. I see an image that shows a structure that could have surgery on it. And I think sometimes the patient is sort of getting a little bit disregarded about like whether or not that person is a good surgical candidate. I guess that is sort of my premise.
I absolutely agree with you. And I do have a personal story to that. I had a fall and I had a knee injury and I went to the hospital. My primary care doctor told me after our examination, you can do physical therapy and get your knee to mobility, right? We can also do surgery and have you get to the same outcome, right? At the end of the day, I'm like, okay, what is the advantage of doing surgery versus just doing physical therapy and getting my mobility? Say, well, with surgery, this is the advantage and this is the disadvantage. With physical therapy, this is the long-term route that you need to do. But the advantage is that with surgery, it's 50-50, that if anything go wrong, you may never walk again, right? And with that, I choose to do physical therapy. I did physical therapy for a year and I still use my knee. I don't run for a long time anymore, but I walk, because that is the outcome. If only you walk and put mobility, like you talk, and balance to your knee, we don't have issue. And this thing I'm telling you is like 6 years now. My knee is very functional. I have no need to do the surgery. Versus if it was just like, oh, this knee is bad, surgery straight, right? I may get the same outcome or I may get the 50-50 flip side, right? Nobody knew, but I mean, that is just to support your point. But what I wanted to ask you is this. In a system, and I see this a lot, we prioritize volume and overtime because everybody just want to make sure that we crunch that administrative numbers and all whatnot. As physical therapists, how does this affect you guys professionally and emotionally?
Yeah, I mean, I always say that physical therapy is one of the greatest professions to be in, because we have the ability to actually change people's lives, right? I mean, I have the ability to really change It doesn't happen. It certainly doesn't happen every day. But there are people who, because you got their back moving or hip moving or whatever, now they can play with their grandkids. They can go and watch that soccer game because they can now walk across the field a quarter mile over uneven ground to go watch their grandkids soccer game. And that made their whole week totally different because they had that experience and they can participate with their family again, which changes everything about their attitude and their goals in life. And so those kinds of stories are incredibly powerful, and they're the kind of thing that keep us going. But it can also be incredibly frustrating when if patients don't choose to do their part, and people start blaming us for, well, my knee's worse from all the from this exercise, or yada yada yada. It can be, there's a lot of yin to the yang in a lot of this. So it can be an incredibly rewarding profession, and it can be an incredibly frustrating profession to deal with sometimes. And so you got to take the good with the bad.
That's true. Thank you so much for that response. And I wanted to ask you, this is going back to the statement you made earlier about, I didn't even know, like, the payment system that physical therapists receive is still like dated to all the way to, like, this is like 20 something. What do I mean? This is like
30 years.
30 years ago.
Yeah.
So we are now looking at the bright side, right? And we have established the import of physical therapy, especially to get our body moving in an economy where everybody gets to work to earn a living, right? But also to stay healthy and play with their kids, and move around and have fun, go vacationing, go hiking like myself, right? So if we are looking towards having that, what would a sustainable health financing model look like for physical therapists, especially those who serve rural community?
Again, I like the idea. If you have a community health center that the community is paying for somehow, adding a physical therapist to that mix could be a very, very powerful thing. First of all, it would take all of the musculoskeletal problems off of that primary care physician's plate, and that primary care physician could focus more on diabetes and high blood pressure and cancer screening and all of the other multitude of things that primary care physicians have to do. And a physical therapist is going to be able to improve, again, balance and endurance and cardiovascular health in a way that helps things like diabetes and high blood pressure and all of those other things. We also do some other niche little pieces, things like vestibular rehab. So there's lots of times where people have dizziness, and we work on something called benign positional vertigo, where there's crystals running around in the inner ear that produce some dizziness. We work with people who have Parkinson's. And they have movement dysfunction because of neurologic diseases and a whole host of a multitude of people. So there's a lot of reasons why a community health organization would want to bring on a physical therapist to reduce the burden on the primary care physician and to assist in improving health before health starts getting in a bad place.
Thank you so much for that response. We will go for a very short break, and when we come back, we'll begin to wrap up these sessions. Do you want to help drive rural health forward? We are looking for passionate volunteers to support our work, from researching to storytelling to outreach. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up. Welcome back. So let me try and see if I can recap all key points of what we have discussed here, and what this reminds me is that pain, as we have discussed in this context, is more than a medical issue. It helps us zoom into the system that is also enabling it, right? How we finance care is important. And you have just mentioned that a community-centered model would really help for rural communities where we also have, like we do have primary physicians, have physical therapies attached to those community centers to really help people to have their adequate mobility. What I also hear is that when people receive early and effective support, it helps them manage their pain better, and sometimes not needing advanced technological kind of care like surgeries and or whatnot. And if that is the case, then there's a clear ground of establishing that surgical need before we do that. And in rural communities where movement is important, rehabilitation is important. In fact, I think even without people complaining, there should be a routine, regular physical therapy for just because of the kind of work that they do, so that people can be very healthy bodily, emotionally, and otherwise to continue to do their work. So as we wrap up, Dave, I know that we're going to leave very soon. I want to ask you, if our health system and policymakers truly want to improve mobility, reduce disability and lower long-term health costs, what do we need to rethink about investing in functional care? This is broadly talking about systems where decision makers are looking at all of these things together.
I think that you're exactly right in terms of the barriers to physical therapy. For my community, it's about making sure that copay is reasonable, the number of visits is reasonable. I think a plan that has 24 visits of physical therapy is appropriate. If as a physical therapist I can't help you in 24 visits of physical therapy, like we should be doing something else. But 6 visits is probably not the right answer. I think that payment for physical therapists needs to improve because, again, there are less and less people going into the profession because the math is starting to not work. And because we have less and less physical therapists, we have less and less ability to provide that care for people. I think that as communities, if you could get some group classes going where we're talking about balance and flexibility and strength and endurance, and have a professional kind of oversee that, but you can have people who are not, they don't have degrees or whatever that are helping out with people. You don't need 20 physical therapists for 20 people. You need 1 physical therapist for 20 people, and maybe 10 other people who can stand by somebody who has a little bit of poor balance to make sure that they aren't falling when they're trying to do some of these exercises. So there's a lot of different ways where you can scale up the knowledge that a physical therapist has to benefit a community in a way where they don't have to be 1 hour to one person. And there's a lot of ways. I think I really like the idea of if a physical therapist came in and saw patients twice a month, but then had the availability to do a telehealth visit to check in on the person and see how those exercises were going, and then maybe talk about some other things that they could be doing if those exercises become too easy or and that sort of thing. So that's a really nice model as well.
Thank you so much, Dave, for bringing this perspective to this conversation. Your work reminds us that good care often starts long before surgery or medication, and that investing in movement, prevention, and access is an investment in a healthier community. To everyone listening, thank you for joining us on today's episode of What About Rural Health? If today's episode moved you, challenged you, or make you think differently, please follow, subscribe, and leave us a review on your favorite podcast platform. And as always, let's keep asking the question, what about rural health? Until next time, I am still your host, Chinasa Imo. Bye for now.